Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more.
In today's episode, we will be chatting with Dr. Andy Barkmeier, a vitreoretinal surgeon here at the Mayo Clinic, about diabetic retinopathy, where we stand today in his care, and his work on the effects of GLP-1 receptor agonists and SGLT2 inhibitors on diabetic retinopathy.
Dr. Andrew Barkmeier is a vitreoretinal surgeon here at Mayo Clinic. Dr. Barkmeier sits on the executive committee for the DRCR Retina Network, is a member of the Macula Society, the Retina Society. He's heavily involved in clinical research involving diabetic retinopathy, retinal vascular disease, telemedicine, healthcare delivery, and complex vitreoretinal surgery. He is a past Mayo Clinic Ophthalmology Program Director and Program Director of the Year and Ophthalmology Teacher of the Year Award recipient. Welcome, Dr. Barkmeier.
Thanks for having me.
We're so happy you're here. We love talking about retina.
It's the best.
It really is.
I don't know about that.
I made you say it.
No, it's nice to dive into our specialties and just our expertise on topics that aren't atypical for whether you're an oculoplastic surgeon or me in peds and strabismus. Just fascinating to learn from each other. So we appreciate the opportunity of doing that today, given your expertise in diabetic retinopathy and some of your recent research.
We have an awesome paper today that you spearheaded this paper that we're going to talk about as kind of a journal club and to talk about your work on this paper. I think it's really topical and important for treating diabetic retinopathy. And then before that, we'll just kind of talk about diabetic retinopathy in general. So the paper for our listeners is the comparative effectiveness of GLP-1 receptor agonists, SGLT2 inhibitors, DPP-4 inhibitors, and sulfonylureas for sight-threatening diabetic retinopathy. This is in press with Ophthalmology Retina at the time that we are recording. We'll link the article so that you all can see it. So we're excited to talk about it. But before we get into all of this, can you just give us an overview on diabetic retinopathy? I know you and I were chatting. I mean, since I was in training, a lot has changed. The landscape of intravitreal injections and anti-VEGF treatment, lasers. Kind of talk us through your algorithm for treating diabetic retinopathy and how it's changed.
Sure. So there's been a whirlwind of change over the last 15 years, really. And a lot of that started with the anti-VEGF medications, which really changed how we manage diabetic retinopathy, in all its manifestations. But diabetic retinopathy starts with taking good systemic care of yourself, and all of the medications and systemic treatments that we know to give people the best chance to not develop diabetic retinopathy and then to lower the risk of progression. But once someone has sight-threatening diabetic retinopathy, which we really look at treating diabetic macular edema, which is one of the top causes of vision loss, and then proliferative diabetic retinopathy, which is development of the new proliferative blood vessels that can then threaten vision through vitreous hemorrhage or retinal detachment. There are a variety of treatments depending on how patients present and what stage they have and what the top risks are for them losing vision. So if we have a patient that presents to our retina clinic with diabetic macular edema, the first assessment is with an OCT. So OCT guides most of what we do for macular treatments these days. And we first assess whether someone has center-involving diabetic macular edema. Mm-hmm. And our trials have really defined this based on which machine you're using and whether someone's male or female. And if you meet certain criteria for center-involved diabetic macular edema and your vision is 20/32 or worse, then we start treating people most of the time with anti-VEGF agents. And we have a lot of nuances for how that's done, and everyone has slightly different practice patterns, but anti-VEGF medications have been shown to have a very favorable risk profile and have excellent visual outcomes over the first 2 years and beyond. So that's how we treat people with center-involving diabetic macular edema who also have vision loss past 20/32 or 20/40, depending on the situation. And then for people with better vision, with or without center-involving diabetic macular edema, we can either treat those patients with anti-VEGF agents. Sometimes we still use laser photocoagulation, And sometimes we can observe them because we've learned from some of our trials, including the Protocol V trial from the Diabetic Retinopathy Clinical Research Network, that many patients with center-involving diabetic macular edema but still have good vision, they do just as well if you wait to see if they start losing some vision rather than treating right off the bat. So for diabetic macular edema, we have these anti-VEGF medications. We have laser, which we still use sometime in select situations. And then sometimes we use steroid medications for patients who don't completely respond to anti-VEGF medications or for some other situations.
Sure. Okay.
Can I ask one question about that?
Of course.
Define center involving. I mean, I was trained back in the days of clinically significant diabetic, macular edema. In terms of, it's really not a clinical 90 diopter lens thing.
It's
the OCT.
finding.
Right.
And in terms of if your the foveal center defines, center involving, or is there anything else around that gets, does it have to be a certain size or certain area, or it's just
Absolutely. Yeah. So there's been so much clinical research on diabetic macular edema in particular that it's become very technical in how we look at specific cutoffs for treatment and who to treat in certain situations. So center involving diabetic macular edema involves if the average of the central 1 millimeter zone on OCT is greater than, for example, 320 microns for a male patient on the Heidelberg Spectralis machine, that would qualify as center involving diabetic macular edema. For a female patient on the same machine, it would be 305 microns.
Wow.
And then on the Zeiss Cirrus machine, it would be 305 microns for males and 290 microns for females.
Okay.
You just dropped those numbers. That's so impressive. You guys are numbers people.
We work with these
I
every
love
day.
it. That's
Yeah.
amazing. That's amazing. And then, okay, so that's your DME protocol. And then take us through diabetic retinopathy and how that differs, or proliferative diabetic retinopathy.
Yeah, so along the spectrum of diabetic retinopathy, for people who do not, let's say for people who do not develop diabetic macular edema, you can progress from mild diabetic retinopathy to severe diabetic retinopathy. And then once you develop severe diabetic retinopathy, you have about a 50% chance over the next year for developing proliferative diabetic retinopathy.
Right.
And then once you develop new abnormal blood vessels and fibrovascular proliferation in the retina, we call it proliferative diabetic retinopathy. And at that point, we have a new treatment strategy for patients in that situation. We're guided by trials such as the diabetic retinopathy study from the 1970s and the ETDRS, early treatment of diabetic retinopathy study from the 1980s and 90s. Mm-hmm. And those tell us who can benefit from panretinal photocoagulation or laser photocoagulation of the peripheral retina to reduce the chance of severe vision loss from proliferative diabetic retinopathy. Mm-hmm. And it also defines what some of the characteristics of high-risk proliferative diabetic retinopathy are. And we still use those criteria very, very commonly to this day. We do, however, have new options, including the anti-VEGF medications for management of proliferative diabetic retinopathy. And the Diabetic Retinopathy Clinical Research Network Protocol S showed us that if you use these anti-VEGF medications to treat proliferative diabetic retinopathy or use the panretinal photocoagulation, you get relatively similar visual outcomes at both 2 and 5 years. Most of us still use panretinal photocoagulation, however, because for people with proliferative diabetic retinopathy, if you for some reason are not able to continue to follow up with your eye care provider, and we've shown that a relatively significant percentage of people are not able to keep regular appointments for one reason or another, you have some more durable protection from panretinal photocoagulation. And one of the things that we're really interested in studying more over the next few years is the effect of these combined treatments using both anti-VEGF medications and panretinal photocoagulation. Because in reality, that's what most people are using in practice. We just don't have perfect data to guide us on what the best strategies are at this point.
Makes sense that would work. One thing that really strikes me about the changes that have happened in how you clinically treat these conditions over the past 15 years, like you said, is how much the retina community has had to grow and evolve and change their practice patterns. And that's got to be challenging. I'd be interested to hear how you've seen it as a practicing retina doc who've been like right in the middle of all the changes from training. Like when you trained, it was probably totally different to now. How do you, as a community, expect all the retina faculty, or not even faculty, just retina docs, retina surgeons, to keep up with the times, keep up with the data? Because that's challenging for everybody. Like, are you reading the new data? But it's imperative in your specialty. And I feel like that's kind of different than other places. What's that been like?
Well, we have the luxury of a wealth of data and information to guide us, and diabetic retinopathy is one of the more common things that we see. So this is something, as a retina specialist, we see day in and day out. So we become very fluent in all the subtle treatment algorithms, and we're guided and subtly shift those treatment algorithms based on new data that comes out. So within the retina community, there are some differences in practice patterns that are relatively subtle, but it's pretty well ingrained what we do. We still need to communicate that with everyone else to make sure that people are getting referred at the right time, and to make sure that we sort of set the course for what the next phases of what we want to learn, what we want to optimize in these treatment algorithms. And that's where some of the upcoming clinical research will continue to guide us.
And prior to stepping into this article that I think it highlights the importance of systemic management decisions on eye complications, I'm struck by in the peds world, we don't see nearly the diabetic retinopathy. They're type 2 diabetes or type 1 are diagnosed, and then oftentimes managed, and we get them into screening protocols. But their management's really changed, even in regards to their primary disease. I mean, the days of finger stick and insulin injections are still there in some populations. But share with us, before we get into your article talking about newer meds, just how the old med of even insulin, and what percentage of patients, or what do you see in terms of how often pumps are being used, or other glaucoma treatment or diabetes treatment, insulin management paradigms have shifted in terms of primary care?
Yeah, so for type 1 diabetes, insulin is still, the mainstay of treatment, and the technologies are fantastic. Like the new technologies to monitor real-time blood sugar levels, to have insulin pumps that can respond to that without active intervention by the patient or the care team is really phenomenal. And we see that there's been a lot of improvement in glycemic control related to that. And we know that that's going to continue to pay off for these patients over time, because the most critical features, the most critical clinical indicators of what your risk of diabetic retinopathy complications are duration of diabetes and how good your glycemic control is over time. So these new technologies are helping incredibly. And then on the type 2 diabetes front, the new medications that we're witnessing a whirlwind change. Right now, all of a sudden, there have been dramatic differences in practice patterns after relative stability for a decade or two. And that's going to be exciting to learn how to optimize the systemic care. And then on our end, as ophthalmologists and retina specialists, how to help advise individual patients and primary care teams to help us all take best care of these patients.
Yeah. So tell us about the inception of this paper, really. You're looking at these new medications for systemic treatment of diabetes and glucose-lowering therapy that have really only come out in the past 10, 15, maybe 20 years. So pretty new meds. We've got the GLP-1 receptor agonists, the DPP-4 inhibitors, SGL2 inhibitors. Those are kind of the main ones that you're looking at. And they've all shown benefits in cardiovascular disease, kidney disease, but question mark in terms of what they're doing for eye disease.
Right. So this study was spearheaded by Dr. Rosalina McCoy, who is an internist and endocrinologist here at Mayo Clinic. She's now at University of Maryland. And she had a grant from the Patient-Centered Outcome Research Institute to look at the impact of these medications on a number of different systemic outcomes, including some cardiovascular outcomes. And then we teamed up to look at these eye outcomes, because there has been a an avalanche of new studies on these medications. And the real breakthroughs have been that these medications, specifically the GPL1, RA, and the SGLT2 inhibitors, have shown that there are cardioprotective and renal vascular protective outcomes from these medications, which is new for people with diabetes.
Independent of glucose lowering.
Absolutely.
That's what I thought was so interesting. So they have something else, anti-inflammatory or something else going on, neuroprotective going on.
Yep.
That's really cool.
We always had these caveats for some of the systemic management that we haven't actually been able to show major macrovascular differences or even mortality outcomes with some of these medications, but what we used to classify as these microvascular, the renal and the ocular outcomes have shown benefits, and we have a wealth of data on the ophthalmology front for that. But these new findings have led to many, many, many new patients being prescribed these medications. But the way that these have been studied for cardiovascular disease and these renal outcomes didn't lend themselves well to study the ocular outcomes. So we don't know what those impacts are. There was a study in 2016 called the SUSTAIN-6 trial that showed that over 2 years, there was an increase in adverse diabetic retinopathy outcomes like vitreous hemorrhage or need to be treatment for diabetic retinopathy. But we didn't know exactly what to make out of that information. What we have known for a long time is that when you start treating someone who has not had good glycemic control, and then they come under very good glycemic control, there can be adverse retinopathy outcomes for the first year or so. However, in the long term, people fare much better. So what's unclear is whether we're just treating patients better with these new medications. So we're just seeing the upfront issues related to diabetic retinopathy, but it's still better in the long term. And we know, going way back to the DCCT study in type 1 diabetes, that it's very clear for the first 18 months that people didn't do quite as well with diabetic retinopathy when they're treated well with insulin.
When they have really tight control.
Exactly.
Yeah.
And then, but beyond that, they do much better.
Okay.
So
that still doesn't make sense to me. What pathophysiologically
we don't know. We don't know.
Okay.
Yeah. It's unclear. But there's something about getting someone under excellent control that changes the retinal conditions in the short term. So these studies are highly motivated to show the cardiovascular and renal outcomes, and those lend themselves very well to 1 and 2 year studies, but diabetic retinopathy outcomes don't do well for that. So this study was chosen to look at a large administrative database, over 370,000 patients.
Huge.
Who received these medications out in routine clinical practice. So we looked at patients who did not previously have any evidence of proliferative diabetic retinopathy or diabetic macular edema, who started treatment with one of these 4 classes of medications, and then we compared the outcomes, whether someone was treated for diabetic retinopathy, specifically for proliferative diabetic retinopathy, whether it's laser or injections, or they were treated for diabetic macular edema with injections or laser. So what we found was that the patients who received these SGLT2 inhibitor medications were a bit less likely to go on to needing treatment for diabetic retinopathy related complications over the first several years. And that was really encouraging because we know these medications are also favorable for the cardiovascular outcomes and the renal outcomes. And also with these GLP-1 medications, we know that they have fantastic systemic benefits. We know that patients are started on these right and left these days, and they did not have any worse outcomes compared to the patients receiving sulfonylureas or the DPPI medications that were used more heavily in the past.
That last statement then, that they didn't have worse outcomes. So that would suspect that the medication, at least in the SUSTAIN trial you mentioned earlier, that suggested that the GLP-1 receptor agonist might be associated with worse outcomes. Would that statement that you just make the suggestion that it really was the insulin tightening of all these that maybe was the reason the SUSTAIN trial find that, rather than a given medication being having a side effect that we didn't understand earlier?
Too short a window.
Yeah, and it's interesting to speculate, and there are lots of different thoughts about how all these different factors are going to balance out and impact these rates. Of course, there are some confounders, and these are expensive medications, the GLP-1 medications and the SGLT2 inhibitors. And so whenever you have a expensive medication, you might have slightly different patients getting those medications. But at this point, because we lack any really gold standard high quality data, it's just encouraging to see that these medications that have these incredible other benefits are not clearly causing worse diabetic retinopathy outcomes. We hope to have some more information in the next few years. There's a study that's called the FOCUS trial that's looking at these GLP-1 medications, semaglutide, over 5 years compared to placebo, compared to no treatment, to see what the impact over a longer treatment time is. But we're not going to have information for another 2-3 years. So this type of study is very reassuring in the meantime, as we look to just guide patients who are sitting in the chair next to us, and also the primary care teams who are taking care of these patients.
Tell us about the team you worked with and the source of data behind this great study.
Yeah, so in addition to Dr. McCoy, this is a true team-based effort. This is a team with experts in epidemiology, statistics, and data science. And the data set is all adult enrollees over age 21 in the U.S. Medicare Advantage, Medicare fee-for-service plans, and commercial plans between January 2014 and 2021.
So you looked at 2 and 5 year outcomes for these 3 different meds, and like you mentioned, the SLG2, did I say that right? Yeah, the SGLT2 inhibitors had the significant reduction in risk of developing diabetic retinopathy, a big risk. I mean, they all decreased your risk, but it was almost 40% risk reduction, 39%, I think. But what was interesting to me, and this is probably a great thing, the overall risk was really low for all of them. It was only like maybe 1% or a small percentage end up developing diabetic retinopathy. So that's great.
Right. Absolutely. So like in an ideal world, we might study in a prospective trial with patients who had a known level of diabetic retinopathy that had some relatively significant high percentage of converting to more advanced retinopathy. Yeah. With this administrative database, all we can do is exclude that someone has prior proliferative diabetic retinopathy or diabetic macular edema treatment. And so we're taking people who are all at very low risk of converting over to higher risk sight-threatening diabetic retinopathy. So in that overall population that does not have a higher concentration of people at high risk of developing advanced diabetic retinopathy, the rate of converting to sight-threatening retinopathy was still relatively low.
But your numbers are huge, your patient numbers in each cohort.
Yes.
50,000, 70,000, 200,000. And so the numbers they're meaningful because they're so big. But that was exactly my question, what you alluded to. It'd be so interesting to see if you started with people who already had a baseline diabetic retinopathy change, and then see if these medications prevent progression to more severe stages.
Absolutely.
That's where the money's at. That would be really hard to do, though, with a big data set.
These studies are very expensive. And there are certain studies that the pharmaceutical industry is highly motivated to hammer down and investigate, and other things that we need to look at in other ways.
Yeah.
So on that note, I mean, as part of Classic Journal Club, you dig through an article and you mine kind of the value of what it's adding to our practices. But, looking back and your role in helping to lead this effort from an ophthalmology perspective, so the greatest takeaways, I think, is we're understanding these drugs more, their safety, and certainly the potential differences between them. But going back, anything about, for the readers out there not having this article in front of them, looking back, what ways would you have loved to have more data, or have, maybe it's just power, but what about this study? It's a retrospective rather than other study designs. But if you could be a genie in the box and go back and start the study again, anything about the study that you wish would have been better, or needs further clarification, or needs to be taken into consideration when people read this article and start to appreciate the impact of these drugs?
So as we develop some of these really powerful data science options, these big data approaches to really querying some of these, impressively huge databases, there are some advantages and disadvantages. And the key is to just understand what questions you can ask well with different types of data sources, what are the inherent limitations, and tailor the questions and the interpretations to what the inherent limitations are. Right. So we know that just looking at coding, for example, clinical coding like ICD-9, ICD-10 coding, we know that we cannot reliably count on those codes for mild diabetic retinopathy versus moderate versus severe. Those are not reliable to use for where an actual patient actually is. You need to use fundus photos and really rigorous methods to do that. So for this study, what we chose to eliminate some of the patients who had known advanced diabetic retinopathy, and then consider everyone else about the same and accept that there might be subtle differences between the groups, because you get into trouble when you try to overread the data that you have and try to interpret things where the quality of the data cannot accurately give you what you're looking for.
Yeah, that's perfect. I think this is a great study. Do you think this will change your clinical practice at all?
So this study makes it easier for me to say what we've commonly said is do whatever you can to improve your glycemic control, to monitor your blood pressure, your lipids, some sort of weight control, exercise, all the things that we know are really good for all parts of you with diabetes. Yeah. And maybe if someone's starting a new powerful medication that might rapidly improve their control, we might see them a little bit sooner in the screening. We might be a little bit more likely to keep our eyes open for some early progression. As with any instigation of a new aggressive treatment, you want to see how someone's doing. But just to reassure people that do what's best for you overall, and we'll keep a close eye on your eyes and take good care of you.
Fantastic.
Wonderful. Thank you for enlightening us on how the care for diabetic retinopathy continues to evolve and change, and your role in that.
Yeah, thank you for your work.
Absolutely. Thanks for having me.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website.
Thank you for listening, and we definitely look forward to sharing more